Welcome everyone to the Terminology Leading Practices stream of SNOMED CT Expo 2023. My name is Anna Randolph-Hoyen and I'm an implementation support specialist with SNOMED International, and I will be moderating this session. All questions will be answered at the conclusion of the presentation. For online attendees, please use the Q&A button to type your questions to the presenter, and on-site attendees, please use the microphone provided in the room. I'm now very pleased to introduce Dr. Zulhairi Mohamad from the Health Information Center Planning Division, who will be presenting post-coordination of SNOMED CT codes to reflect workload, cost, and burden of disease in developing dentistry reference set. Dr. Zulhairi, please go ahead.
Thank you. Thank you, Madam Chairperson, for that kind introduction. So, good morning, good afternoon, and good evening from wherever you are. Okay, I'm Dr. Zulhairi from Health Information Center, Ministry of Health, Malaysia. So I'm glad to be here again and share with you some of our experience in post-coordinating SNOMED CT codes to reflect workload, cost, burden of disease in developing dentistry reference set. So aim and objective. So this presentation is first to introduce the Ministry of Health Malaysia effort to post-coordinate SNOMED CT concept to represent workload, cost, and burden of disease in the dentistry reference set. And secondly, to explore other benefits of implementing a single source of truth and post-coordination in MyHDW e-reporting version 2.0 or health. As per introduction, Malaysian Health Data Warehouse, MyHDW, which was established in 2016, is a trusted source of comprehensive healthcare data structured for query and analysis purposes. The data collected in MyHDW is both structured and unstructured in nature. The unstructured data will be codified using SNOMED CT through MyHarmony. Previously, e-reporting for oral health was collected through manual data collection and the Health Information Management System HIMSS e-reporting system. So the nature of data is aggregated, but due to its inefficiency, MyHDW e-reporting version 2.0 or health was introduced. So e-reporting version 2.0 or health was developed as one of the source system for MyHDW to replace its predecessor, HIMSS e-reporting. Most of the source system in MyHDW were designed for structured data analysis. However, e-reporting version 2.0 or health incorporates both structured and unstructured data analysis within one source system due to its integration with MyHarmony, which allow harmonization and codification of free text. In e-reporting version 2.0, 11 out of 14 submodules were involved in analysis of unstructured data, 3 from primary oral healthcare and 8 from specialist oral healthcare. So this picture shows a diagram for MyHDW source system. There are two types of service for oral health program reported in MyHDW, primary oral healthcare and specialist oral healthcare, each of which can be further divided into non-patient-based and patient-based services. So for e-reporting version 2.0 or health, we can further divide it into structured data entry and a combination of structured and unstructured data entry. So for unstructured data entry, e-reporting version 2.0 or health originates from the free text box labeled surgical or medical procedure information, where clinicians are required to input information about the procedure performed during each patient's visit. Notably, I have entered temporary filling 1122 in the text box as shown in picture 2. MyHarmony subsequently harmonize and codify this free text into SNOMED CT concepts and codes for further analysis. The codified unstructured data is then represented as a numerical value in tabular format. So in picture 3, the data flows for e-reporting version 2.0 or health is depicted. For patient demography, patient names, ID number undergoes anonymization through the privacy and anonymization service. Other structured data will remain the same. And the unstructured data is then codified in MyHarmony, written free text, like I give an example earlier, temporary filling is codified as 173326008, insertion of temporary dental filling in tooth procedure. Tooth 11 is codified as 2212004, and tooth 22 is codified as 257480002. This will later be translated as 2 temporary fillings in their respective column in a fixed format report, FFR, which is done through MyBase, business intelligence service within MyHDW. So what is fixed format report? Since its inception, the oral health reports have consistently been generated in a fixed format report, FFR, which is a predetermined tabular format required for report submission to the Ministry of Health Malaysia. This format has been the preferred choice despite other reporting options available in MyHDW, such as ad hoc query and dashboards. These reports serve to provide information for policy making, strategy formation, resource allocation, and performance evaluation at the state and national levels. From the interaction with subject matter experts, their FR reflects their workload and helps with assess the disease burden and associated costs related to oral health. So this picture briefly describes what is FFR for reporting. The first picture describes briefly about the primary oral health care report, PG207, as demonstrated above. And for the restorative dentistry specialist oral health care, as demonstrated below. So for mapping of SNOMED CT concept, so for this presentation, we have selected 3 reports from primary oral health care services and 1 report from specialist oral health care service for comparison, as listed in the table. So for your information, our reports are in our local language, which is Bahasa Melayu or Malay language. So I took the liberty of directly translating this report into English for further understanding. So during the early development in year 2008, the use of SNOMED CT was introduced to dentistry due to its granularity and vast terminology. SNOMED CT incorporates numerous dental procedures, particularly those related to specialist oral health care, where a wide range of procedure is performed. SNOMED CT also assigns a standardized code to each procedure, facilitating analysis, integration, and interoperability with other systems. So we don't find any other standards that we could use to represent, especially our specialist oral health care procedures. So the oral health report is constructed by mapping structured and codified unstructured data into specific column within Malaysian Health Information Framework, MyHIF. So each column in the procedure section is meticulously mapped to one or multiple post-coordinated SNOMED CT concepts. So this concept should be unique in each column in a report, allowing clinicians to obtain the desired number of procedures and preventing duplication. So picture 6 demonstrates MyHIF, the status of attendance and diagnosis for specialist oral care, which is not represented here is actually captured through structured data analysis. So for fluoride application procedure in column 4, we map it to a single concept 2372000 topical application of fluoride to procedure. This should later be translated as follow. When a patient receive fluoride application, whether for the upper arch, lower arch, or both arches, in one visit, it will count as 1 for that column. So for preventive restoration, there are post-coordination of 2 SNOMED CT concepts. So for example, if a patient receives treatment for PRR, preventive resin restoration type 1, so it will count as the number of teeth, whether permanent or decidus, that have been restored with PRR type 1 restoration during each visit. So this picture illustrates how we map the insertion of composite restoration into tooth as the main concept to new qualifier value, because new for us represent a new visit and repeated visit. So and to the other concept for coding and analysis. So for example, when clinician writes new composite restoration on tooth 11, it will code as follow 237890004, 7147002, and also 221200004. So codification for amalgam restoration for repeated amalgam as shown below. For example, amalgam filling on 55 should follow the same process. So another picture illustrates how we map insertion of complete dentures and tooth extraction to other concepts during the early development. So for recent development, in year 2022, there was a need to create a new mapping for several reasons. Firstly, requirement changes occurred in December 2021 by subject matter expert, introducing a new glossary with a few different needs. And then there is a post-coordinated concept in the early development project did not accurately represent the desired numerical requirement of subject matter experts. And we acknowledge that our inadequate knowledge for terminology selection for concept led to issues such as selecting the wrong concept and concept not matching the clinician writing for unstructured data analysis. So during this new development, subject matter expert and us selectively chose all the SNOMED CT concept from the international edition March 2022 release, which this mapping will allow us to establish a baseline reference set later on. So this picture illustrates the difference between mapping in 2021 and 2018. So in 2021 requirements, we map tooth extraction 55162003 to tooth structure. So this concept best fits the clinician writing, such as extraction of 11, extraction of 51 under local anesthetics. So we removed the previous 3 concepts as we agreed that it's not natural to write those concepts with tooth structure. So here's is another new mapping involve composite and glass ionomer restoration to tooth and tooth surface. And this one is also applies to amalgam restoration. So these pictures illustrate 5 most used main concept in the 4 reports and its relationship to other concepts. For example, tooth extraction procedure is mapped to permanent teeth and its supernumeraries. So some main concepts such as amalgam restoration, composite restoration, and glass ionomer restoration is mapped up to 4 other concepts, which is a 5-tier hierarchy. So for discussion, there are 557 main concept mapped with each column for the 4 reports, with more than 50% of the concept being distinct. 57.3% of the listed procedure needed post-coordination. For primary oral healthcare, they map about 71 distinct main concept to their 3 reports, while restorative dentistry specialists map 246 distinct main concepts to their reports. So this difference is due to the mapping of process and procedure into the specialist reports. A process is defined as a big picture and highlights the main element of your business, while a procedure captures those elements and adds more information for functional responsibilities, objective, and method in them. So some elements of the reports could imply costs, since many procedures listed in the data charges have been mapped into the report. Composite, glass ionomer, and also amalgam restoration are built based on the number of filling, while scaling, tooth extraction, dentures, and crowning are reported according to the dental charges. So however, a few procedures such as fluoride application, root canal treatment, posteriorities especially are mapped differently. So disease such as caries occurrence can be deduced by mapping of each tooth to all possible surfaces. This approach can also indicate the extent of caries within the population at a specific time. However, other diseases here are not addressed. So these four reports best represent the oral healthcare workload, demonstrating the different requirements presented by primary and specialist oral healthcare. However, SME define workload differently as a personal or subjective. The restorative dentistry specialists include all the process and procedure in their reports, while the primary oral care didn't. So cost and burden of disease are less likely to be presented in these reports. Unfortunately, we are unable to demonstrate the use of SNOMED CT on forensic dentistry or forensic purposes as a source of patient records during their forensic investigation, since it's capture. However, it's possible for e-reporting version 2.0 oral health to serve as one of the source for patient records during a forensic investigation, since it captures granular data directly from each patient. So setback from mapping to FFR for report analysis include the following. So our system could not accommodate sudden changes in the requirement of SMEs. My HIF mapping and the reference set need to be updated, thus incurring additional costs. So our reference set is dependent on a specific SNOMED CT version or edition. With an update, more concept may be inactive or obsolete. And during development, we identify the exact synonym map to one or more concepts. So due to the system inability to codify two sets of the same terminology, analysis could not be performed. And then we also found coding special characters in SNOMED CT concepts or synonym proved to be a challenge to us. So in conclusion, post-coordination SNOMED CT codes in MyHW reporting version 2.0 health project is useful, and it caters to our needs, enables the collection of granular data, provide a wide range of analysis and interpretation. A sudden change in requirement proved to be a challenge. Issues such as inactive concepts and change in codes, synonyms can have a significant impacts on the system, ultimately incurring costs. For future works might not be possible if the usefulness for the purpose other than generating FFR is not appreciated. And a message from the oral health working groups, we acknowledge SNOMED CT is a highly complex and extensive terminology with a vast number of concepts, relationship, and attributes, but healthcare organization needs to keep their system and staff up to date with the latest release, which requires ongoing resources and maintenance. So this is my reference. I would like to acknowledge this person and also the organization. And for that, thank you.
Thank you very much. Dr. Zulhairi will now take any questions. So if you are in the room, please go to the microphone in the center to ask your question.
Thank you, Dr. Zulhairi, for a great presentation. Our company's new presentation. Have you looked at using these different post coordinations for cross analysis? Are you looking at, like, what I'm thinking about is, are you looking at analyzing which tooth are more exposed to what kind of building, other kind of building? Are you actively using the different post coordinations in creating such kind of data sets? Do you understand the question?
No, please rephrase it. Sorry.
What I'm thinking, like you said, you were charting a filling and then you were tying it to tooth and surfaces.
Yeah.
You're doing that for building purposes. What it sounds like it's building purposes.
Yeah, it sounds like it.
Yeah. Have you conducted any analysis, say, based on saying if there are more positive restorations on one kind of area of the teeth and more amalgams on other areas? Have you done any? Are you
I see.
using the post coordinations for analytics, and are you using SNOMED's hierarchies to perform those kind of analytics?
Actually, our system allows us to do that analysis. Right now, we are prioritizing the fixed format report, which is required by the subject matter experts. And earlier, I've emphasized because they reports is actually mostly represent workloads. So their definition of workloads is rather different. So, but the system, if you see, if you notice it, actually, since we go granular, we take patient demography, and then the submission rate is based on patient clinician data entry at a certain time, at a certain level. So we can do some analysis, extra analysis, despite for the FFR report, meaning we can demonstrate how extensive the caries, where is the location that these caries or this extension of caries happen at certain period of time, because the system allows it. But the main priority, like I presented earlier, is we have to represent the numbers exactly like the SME required. So that's the main issue for us right now. Yes.
You said there were some limitations on the use of SNOMED concepts as numbers. SNOMED CT has supported concrete domains since 2021, because obviously numbers is an unbounded set, so we don't want to have to create a concept for every possible number, although the count critique is obviously quite restricted. Have you considered using concrete values if they're not?
Can you rephrase that? So I couldn't understand the question actually.
Now in our model,
Yeah.
we just use the numbers directly.
Yes.
We don't need to use a concept for each number. And in fact, we've now inactivated those concepts. So, for example, in medicinal products, it's 500 milligrams of paracetamol. We just say 500. We just use that number directly in our model.
All right. So for actually for us, for codification of tooth, we take extra steps. So this one is built within my Harmony. So we don't use any extra tools that to try to codify, as for example, tooth. If you say 1-1, this one is directly translated into codification for that tooth. So as we have to do some local we have to do it. We have to use the My Harmony itself for codification of tooth. But we have the issue with us is another thing is we also use for example 1-1. That one also could codify as a qualifying value. So there are certain things that we have to do within our system in order to code that 1-1 system could differentiate either is those or is a qualified value. So I think that one is we had this done at our level, but we don't use any extra or any other tools that I think Smart City produced.
Thank you.
Thank you.
Just a quick question on whether you are using the data now to create guidelines for care. Are you identifying that, let's say the 5-year-olds and under are getting, as an example, fluoride treatments? Are you seeing that there's a pattern that reduces the decay and therefore you're saying everyone under 5 years old should get fluoride treatment?
Actually, ideally, our system could give you that numbers, because we, like I said earlier, demographically we differentiate patient by age, so we could imply that, and then the source system allows us to cater to capture data, and then we can compare it within by years, so it allows that. But like I said earlier, the numbers right now doesn't represent the needs. So I think ideally we can perform that, but yeah.
Thank you very much, and thank you for your questions. So with that, we'll conclude this session. So thank you very much, Dr. Zulhairi,